First of all, I'd like to thank everyone here for inviting me, especially Arthur, which actually is really a very good friend over the last 2 years. You know, we are doing plenty of work together. He is awake 24/7. He is responding to each email within 2 minutes, and everything is very clear. And just, you know, thank you for inviting me. You have a beautiful city, beautiful people. I don't have enough words to say what I feel. Thank you. So I was asked to speak about hematological malignancies in pregnancy. And, you know, we don't have many malignancies, but too many in order to speak about all of them during pregnancy within half an hour. So I have decided to speak about lymphoma and myeloma, but mainly just provide few principles for managing patients diagnosed during pregnancy. So we can agree the diagnosis of cancer during pregnancy is a traumatic and poses a substantial challenge to the patient, to the family, and to the doctors and to the nurses. The need to treat a potentially lethal disease, together with the concerns about adverse fatal outcomes, raises therapeutic, ethical, and many social dilemmas. I am a member of the INSIP, which is a group that was initiated at Leuven, looking at patients who are diagnosed with cancer, solid cancers, but also hematological cancers during pregnancy, looking at these patients prospectively. And according to their data, which I'm sharing now with you, it seems like about 1 out of 1,000 pregnancies ends with a cancer. The most frequent cancer is breast cancer, which accounts for more than 50% of the cases, followed by hematological malignancies, which account for about 16% of the cases. It seems like cancer is the second most common cause of maternal death after gestation-related vascular complication. The prevalence of cancer during pregnancy is expected to rise in developed countries because of the increase in average age at pregnancy. However, the low incidence of hematological cancers during pregnancy has precluded large prospective controlled trials. Hence, data are mainly restricted to retrospective studies, case reports, and reviews which we are publishing without having enough data. So I think the main question, which usually all my patients are asking me, is it because of my pregnancy, doctor? Did I get it because I decided to become pregnant? And the answer so far is no. We don't know about any causative association between pregnancy, the hormonal changes which are associated with pregnancy, the immune suppression which is associated with pregnancy, and the development of hematological cancers. However, we do know that many of patients who have lymphoma, their cells are positive for both progesterone receptors and estrogen receptors. However, none of these cells seems to actually proliferate more vigorously in the presence of external administration of estrogen and progesterone when we investigated it in the lab. The only thing I can say that actually we have looked at the outcome of mice having lymphoma in the presence and in the absence of pregnancy, and the mice who had lymphoma who were pregnant died earlier. We are looking now for the mechanism, but we still don't know. The only thing I can say that it was not due to the higher level of estrogen and progesterone. One of the hypotheses is the fact that during pregnancy, there is a significant immunosuppression, part of the tolerance between the fetus and the mother, which might be the reason for this association. When we're treating a patient with cancer during pregnancy, we are facing a few challenges. First of all, diagnostic challenges. We know that there are overlapping symptoms between pregnancy and hematological cancers. And I'm sure that all of you have seen a patient coming to your clinic who was eventually diagnosed with Hodgkin lymphoma. And she was complaining about shortness of breath, cough, night sweats. The doctors thought that everything is caused by the pregnancy, and unfortunately, she was diagnosed with lymphoma. We also know that there are overlapping lab values. For example, LDH is usually increased or is often increased during pregnancy. And of course, it is often increased in lymphoma. We also should consider the dilution effect. We have no idea regarding the ratio, the level of FLC during pregnancy. I am following now a patient who is 37 years old. She is now on week 27. And her light chains are very stable. However, she presented last week with a new bone lesion, new lytic bone lesion in her sternum. And the light chains remained the same, the M protein remained the same. Her disease is mainly presenting with a light chain, and the M fraction is very small. But we don't have actually any data regarding the values of FLC during pregnancy. And of course, we have to decide which imaging we can perform at one stage of pregnancy. So we should remember that, when a patient is coming, for example, to I&E and she is pregnant and we're afraid, can we do an Xray? Shouldn't we do an Xray? Can we do a CT scan, an MRI? Usually we say, no, we shouldn't do anything, which is absolutely wrong, because the threshold dose for fetal dose is 10 CGY. We know that a higher dose is associated with a risk for fetal abnormalities, IUGR, and many other complications, but we should also remember that there is a chance for secondary leukemia in offsprings who were exposed in utero to radiotherapy. Nevertheless, Xray, chest Xray is associated with a very low irradiation dose, as you can see here. CT of the thorax, also a very low dose, which is below 10 CGY. However, a CT of the abdomen and especially a CT of the pelvis are being considered to be risky, especially a CT of the pelvis, and therefore should be avoided during pregnancy, whereas a CT of the chest is completely reasonable if you have a suspicion for a PE, for a disease, or anything else beyond second trimester. PET CT scan is completely forbidden, being associated with higher risk for teratogenicity, for fetal death, and also for secondary leukemias. MRI is actually considered to be the best way to monitor and diagnose your patient. After diagnosing the patient, of course, we need to take a tissue sample, lymph node or a bone marrow biopsy, which are completely reasonable, which we can do easily during pregnancy, no matter which stage, even at very early stages. However, we have to face the therapeutic challenges. We know that our goal is to provide the best therapeutic regimen without adversely affecting the fetus. However, we have limited experience due to the rarity of hematological cancers during pregnancy. We have a limited number of agents that are known to be safe, and most of the agents were looked at when they were given as a single agent, and usually in practical practice, we are giving combinational therapies, and there are lack of data regarding the safety of many novel agents. We should remember that most cytotoxic drugs are 250 to 400 kilodaltons and can therefore cross the placenta. Nevertheless, doses used in humans are usually lower than those reported to be fetotoxic in animals. Fetus is most vulnerable to drug-related teratogenicity during organogenesis between week 2 to 8. However, some organs, for example, the eyes, genitalia, hematopoietic system, nervous system, are still vulnerable after the first trimester, and we should remember it. Chemotherapies with high lipid solubility and low protein binding, for example, idarubicin compared to doxorubicin, have an increased ability to being transferred from the mother to the fetus. Nevertheless, despite all these limitations, less than a quarter of fetus are adversely affected when mothers are treated during the first trimester, suggesting that genetic susceptibility might be also affected by genetic factors which are still completely unknown. We should also remember that chemotherapy can also inhibit the migration and proliferation of trophoblasts, which might partly explain the low birth weights of chemotherapy-exposed fetus. Another therapeutic challenge is coming from the fact that there are differences in drug metabolism during pregnancy. There is an increased plasma volume, third space created by the amniotic fluid, and also increased hepatic oxidation and renal clearance. And for example, in this study that has looked at blood levels of several chemotherapeutic agents, including doxorubicin, one of our favorites, you can see that the clearance and the VD are highly increased during pregnancy, resulting in a lower Cmax and ACU in pregnant women compared to non-pregnant women. And again, in another study, looking at the predicted relative changes in the exposure, AUC and Cmax during pregnancy, you can see here, again, that there is a big difference between pregnant versus non-pregnant women. For example, the doxorubicin, which actually is highlighted here in red. However, despite all this data, we don't have any good data to suggest how much we should increase the dose of these agents. And the recommendation is to use the actual body weight and the height and actually give chemotherapy based on these measurements. We don't have any data supporting and telling us, please increase the dose 30%, 50%. We have nothing like that. The next issue is the newborn-related challenges. We know that newborns that were exposed in utero to chemotherapy are more likely to have premature labor, more likely to be IUGR, and we know there is a higher incidence of premature rupture of membranes. We are trying to do our best and perform delivery on time, week 38, 39, as much as we can. However, we should remember not to perform delivery too early, because we should have a gap of at least 2 to 3 weeks after last chemotherapy to avoid fetus myelosuppression and infections. Natural vaginal birth is favored unless the patient has a thrombocytopenia. And if there is an indication for early delivery between week 24 to 34, we should remember to give steroids. The placenta should be examined for cancerous foci. However, this scenario is extremely, extremely rare. And post-delivery thromboprophylaxis is recommended, and I say honestly that we often forget to give it. The next thing that we should remember is actually what happened with these babies who were exposed to chemotherapy in utero. And the study of the INSIP, which was published recently in the New England Medicine Journal, shows very encouraging results. So actually what they have done, they have looked at patients, or actually babies, that were exposed in utero to treatment versus babies that were born to healthy women at the same time. There were 129 babies that were exposed to some kind of treatment during pregnancy. 74% of them were exposed to chemotherapy, and they were compared, as I've said before, to babies that were born to healthy women. The perinatal outcome, that again, 61.2% born preterm. However, when we are looking at the post-natal growth, and we are comparing the two groups, it seems like it's not adversely affected. If we're actually looking at the general health of these babies, they didn't have any other complications which was worse compared to their healthy counterparts. No more visits in the INE, no more operations, nothing like that. When we are looking at the cognitive outcome, the same. When we're looking at a cognitive outcome and chemotherapy cycles, it seems like the number of cycles had no adverse effect on cognitive outcome. However, the prematurity itself had an adverse impact on cognitive functions. Therefore, we should try, as I've said before, to avoid prematurity as much as we can. One of the most common questions which we are being asked is, Doctor, when can I become pregnant again? And we don't have a good answer. There was a publication by Andrew Evans, who have looked at patients that were diagnosed with Hodgkin disease while being pregnant and became pregnant again. And what he saw, that there was no higher incidence of relapse in patients who became pregnant after being treated for Hodgkin while being previously pregnant. However, we don't have any data for this question in diffuse large cell B-cell lymphoma patients, in myeloma or other malignancies. We have some disease-specific challenges. So looking at lymphoma, a 29-year-old woman, week 19, first pregnancy, shortness of breath, enlarged supraclavicular lymph node, biopsy Hodgkin lymphoma, MRI mediastinal cervical enlarged lymph nodes, treatment outside pregnancy, ABVD. What should we do now? Again, ABVD has been shown to be highly safe beyond first trimester. If the patient is being diagnosed in first trimester, we usually try to bridge with vinblastine or with steroids, although there are no data regarding bridging with steroids, but we often do it, and it seems to work. In very rare cases, we have to conduct early termination of pregnancy, but actually, to be honest, I don't remember even a single case like that. We usually succeed to manage and bridge to second treatment with vinblastine or prednisolone, and deliver ABVD afterwards. Safety of novel agents, we actually really don't know. Brentuximab vedotin, I'm sure that all of you are aware of the Echelon study trying to give brentuximab vedotin in first-line treatment instead of bleomycin. So it seems to be actually highly phytotoxic. You should all remember that CD30 is being expressed in many of the fetal tissues from early days almost till the end of pregnancy by the genitourinary system, GI, nervous system, also hematopoietic system quite late. Therefore, actually, we don't have clinical data, but the answer is do not give. Safety of anti-PD-1 checkpoint inhibitors. Again, no data from humans, but it seems like it's not going to work. I just mentioned before that there is a tolerance between the fetus and the mother, and part of it is attributed to the PD-1, PD-L1 pathway, and abrogation of this pathway seems to result in a higher fetal loss. I'm moving to diffuse large cell B-cell lymphoma. Again, a young woman diagnosed eventually with diffuse large cell B-cell lymphoma, high IPI, which means like that in the outside pregnancy, we would have treated her with rituximab CHOP in combination with high-dose MTX because she has a high risk for CNS relapse. So looking at the INSIP data, these data actually have not been published yet. They have looked at 65 non-Hodgkin lymphoma patients. As you can see here, most of them had diffuse large cell B-cell lymphoma. And what was interesting, that 34% of these patients were diagnosed with stage 4, which is not actually very frequent when we are diagnosing diffuse large cell B-cell lymphoma in young women. Looking at a series that we published in Diagnostic Oncology 2013, there were 121 patients diagnosed between 1967 and 2011, reported in 74 papers. 75% of the patients were diagnosed at stage 4 disease, much higher than expected. What was also interesting that many of these patients had a very highly aggressive lymphoma. And the most interesting issue was the fact that actually many of these patients had reproductive organ involvement, involving the uterus, the cervix, the ovaries, and the answer, we don't know why. We don't have a good explanation. The usual treatment for these patients beyond first trimester is rituximab with CHOP. All of these agents, when they are given during first trimester, might be teratogenic. I'll not go through all this list. I'm sure that you all know it. But after first trimester, it seems like the teratogenicity is very low. Again, a higher incidence of IUGR and fetal loss, but most of the babies will actually survive the chemotherapy, and the delivery will go uneventfully. We should remember that we should avoid a high-dose methotrexate during pregnancy, and if we need to give it, we should give it beyond week 20, because otherwise we are at high risk for that the fetus will develop aminotreptin syndrome, which is associated with a white nasal bridge, with cranial abnormalities, with hypertelorism, and therefore it should be avoided, and if there is no option, at least give it beyond week 20. Rituximab was shown a few years ago to be very safe during pregnancy. I'll not go through all details, but practically no increased incidence for teratogenicity, even not when administered in the first trimester. The only thing that was shown that there is a transient lymphodepletion in some babies and some thrombocytopenia, but without increased incidence of life-threatening infections. Looking at the INSIP data, it seems like the outcome of these women is very encouraging. You can see here that although it's a mixture of low-grade and high-grade lymphoma, most of them had high-grade disease. Actually, 94% of them had the aggressive lymphoma. The outcome seems to be very good, despite the fact that 34% were diagnosed with stage 4. However, when we are looking at our paper, Lancet Oncology, the outcome seems to be worse. I can say that actually it was, as I've said before, data which started in 1967. Many of the data came from in non-Western countries. So I think, the difference reflects these differences. So if we have to manage a patient with diffuse large cell B-cell lymphoma, again, if the patient is being diagnosed beyond second trimester or beyond first semester, R-CHOP, postpone MTX after week 20. If the patient is being diagnosed during first trimester, consider early termination of pregnancy. Indolent lymphoma, what are we going to do with this? Usually wait, and try to postpone treatment as much as we can. Multiple myeloma, about 45 cases were described in the literature so far. I think that all of us are aware of the fact that it presents diagnostic and therapeutic challenges, and we don't have actually very good tools to treat these patients during pregnancy. None of the novel agents is permitted. We usually use short-acting steroids, which are metabolized by the placentas, 11-hydrogenase, where the fetus receives only 10% of the steroids. Prednisolone, 50 milligrams every second day, is commonly being used. However, if a patient needs more than that, we can go to the old VAD, using vincristine, using doxorubicin, using sometimes cyclophosphamide, or alternating between cyclophosphamide together with prednisolone, but we can't give bortezomib or imids. Imids, I'm sure that all of us here know the bad stories with thalidomide, and bortezomib, according to mice models and the monkey models, seems to be also highly teratogenic and results in a high incidence of fetal loss. Daratumumab, we don't have enough data. The only thing which we should remember that CD38 is virtually expressed by T cells, neonatal T cells, but also fetal T cells, very high levels, and therefore, it seems like it's not going to be the solution for pregnant women with myeloma. And the same for the JSK 2857916 compound, which I hope will come shortly to our arsenal, which is directed against CD38 and provides the MMAE to the myeloma cells. What about irradiation? So we should remember that it's quite safe during the first and second trimester, definitely not during the third trimester because of the proximity of the fetus to the irradiation, and we are talking only about irradiation of the upper part of the body. And just look in my table here, you can see that, we shouldn't expose the fetus to a higher radiation dose higher than 10 CGY. And, when we're going into the second trimester, only if we actually have a very, very small irradiation field, it can be done safely. Otherwise, should be avoided. We don't have plenty of data regarding the outcome of patients diagnosed with myeloma during pregnancy. I just brought here one of the papers, and it seems like, we don't really know, but when you're looking at the response rate, it seems like to be lower than we expect, of course, with other agents. And how is it going to impact the long-term survival? We don't have enough data. So what actually can we take home? We should remember that, of course, hematological malignancies during pregnancy possesses substantial risk to the mother and fetus, and diagnosis is made difficult by limitations of imaging. The management should focus on the mother's survival while minimizing treatment-related toxic effects. And hypercoagulable milieu induced by pregnancy and cancer can result in maternal and placental vascular complications and might require thromboprophylaxis. So thank you very much for listening.